Okay, so I think this study addressed an important clinical question, which is what to do with the oral agents when initiating insulin. And the recommendations are quite vague in that regard, just to do what you want and according to the characteristic of the patient. And so that's fine, but at the end of the day, the surveys told us that it's about 50% of, except metformin, which is kept usually as recommended, the oral agents, especially DB4 inhibitors, are stopped in about half the cases. So, and this clinical decision is not evidence-based. So the study which was conducted was a randomized controlled trial involving patients who were not controlled under sitagliptin plus metformin and potentially plus SU2, so B or 3 oral therapy. And these patients were, the treatment was modified, so they had before randomization sitagliptin plus metformin, and then people were randomized. Basal insulin, glargine here, was initiated, and metformin was continued, and the interventional drug in sitagliptin was kept, or placebo was given in the other arm, so a 2-arm parallel study. The study showed that the titration of insulin was conducted properly, and actually it was done so with a lower FPG at the end of the 30 weeks of the study in the sitagliptin group compared to the placebo group. And accordingly, we observed a change in HbA1c, which was larger in the sitagliptin group, with a difference at the end of the titration, at the end of the study, of about 5 millimole per mole, so about 0.4 to 0.5% of HbA1c. As we can expect, the dose of insulin was less in the sitagliptin group, and despite the better HbA1c, the better control in these patients who were all of them under insulin, we had a similar, or even regarding the event rate, lower rate of hypoglycemia, of non-severe hypoglycemia in the sitagliptin group. Tolerance was, as expected, very similar in both arms, and the conclusion of this study is that when now we have a documentation of what to do regarding sitagliptin in this uncontrolled patient when initiating insulin, we can see that we have an advantage on glucose control, and this advantage is not at the cost of a higher rate of hypoglycemia.